Okay, so I think we can go ahead and get started. Welcome, everyone. Thank you so much for joining us tonight. I'm Mariel Kovo. I'm an internist here at the Animal Medical Center. I'm very excited to be here tonight moderating this talk, and I know we have a great lecture in store for us. So the title of tonight's lecture is Thoughts on Acute and Chronic Pain in the Aging Pet and Human, and it's presented by Dr. Andy Looney and Dr. Dillon Schafer. Dr. Looney earned her doctor in veterinary medicine from Cornell University in Ithaca, New York, where she also completed a residency program in anesthesiology. She spent time teaching at Cornell and Tufts, as well as working in major small animal referral hospitals in the Northeast and New England. Dr. Looney's key areas of interest involve interventional pain management, locoregional nerve blocks, and outpatient chronic pain care. Dr. Dillon Schafer is an assistant professor of anesthesiology at Yale New Haven Hospital. He received his medical degree from Northwestern University Feinberg School of Medicine and graduated from the Beth Israel Deaconess Medical Center anesthesiology residency. Dr. Schafer is a general anesthesiologist with special interests in obstetric and regional anesthesia. He is heavily involved in resident education, serving as the chair of the Clinical Competency Committee and associate director for simulation and anesthesiology at the Yale School of Medicine. He is also passionate about environmental sustainability in the hospital, giving lectures on sustainable practices within anesthesia and working on various projects to reduce waste. Dr. Schafer has always been interested in veterinary medicine and has spent time shadowing veterinary anesthesiologists at the New England Aquarium, Mystic Aquarium, and Central Hospital for Veterinary Medicine. He's honored to be speaking at AMC's 2025 One Health Conference alongside Dr. Looney. So everybody remember to stay until the end of the session. We're going to post a link in the chat where you'll need to fill it out to receive the CE credit. And with that, I'll hand it off to Dr. Schafer.
Thank you so much for that lovely introduction, Dr. Kovo. It's a real honor to be here. I'm going to be trying to share my screen. Let's see. All right. And yes, it's such an honor to presenting about chronic and acute pain alongside Dr. Looney. So I'm going to be talking about pain in the elderly human. So first thing that we need to do is define pain. So pain is generally described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Acute pain is an adaptive type of pain. It's usually protective pain that signals the body for medical assistance or rest. Chronic pain has a few different definitions. It often includes a certain length of time, whether it be 3 months or 6 months. But really, the big difference between chronic pain and acute pain is that chronic pain is a maladaptive and pathological process that tends to cause suffering. So chronic pain affects about 25% of US adults, with estimated costs from disability, lost work, and treatments exceeding $600 billion annually. It contributes to functional deficits, cognitive decline, social isolation, impaired physical activity, dependence on others, and really an inability to work and participate in activities of leisure. And this has a particularly profound impact on the elderly. So pain in the elderly is under-recognized and under-managed for a few reasons. One, misconceptions. The misconception that pain is a normal part of aging, which is not true. There's also communication barriers, hearing, vision, speech difficulties, or cognitive impairment from dementia or delirium. Although obviously, as a human physician, I can't complain about communication barriers compared to my veterinary colleagues. But it does present a challenge. Also, elderly patients tend to have atypical presentations, and they might be more hesitant to report suffering from chronic pain due to fear of extensive testing or loss of independence. And then there's a lot of concerns about treatment risks, many of which are legitimate due to side effects, drug interactions, fall risks. So all of these lead to under recognition, under management of chronic pain in the elderly. So how common is chronic pain in the elderly? So the rate of acute pain is actually roughly the same in all age groups, but chronic pain seems to rise with age until about age 70, at which point there seems to be a plateau. And the problem is that there's a huge range of definitions of pain, and studies kind of looking at the prevalence are variable. So some estimate that, over the age of 65, up to 60% of patients have chronic pain. So osteoarthritis, back pain, headaches, those are the most common pain-related conditions in all adults, but the elderly population also suffers from pain from chronic disease like diabetic peripheral neuropathy, cancer pain, post-stroke pain, vascular disease, and post-herpetic neuropathy. They've consistently shown that institutionalized older adults have higher levels of pain than those who are continuing to live in the community. There is a gender difference, with older women having a higher reported prevalence than older men, and elevated body mass index and lower socioeconomic status has been associated with increased chronic pain. I like this image over here, kind of showing that some studies have shown up to 65% of elderly patients have osteoarthritic neck and back pain, 40% musculoskeletal pain, and then followed by peripheral neuropathic pain and chronic joint pain. And one study showed that about a fifth of older adults had pain at 4 or more sites. Um, so how is pain perceived differently in the elderly? So elderly patients have an altered pain experience with changes in pain processing and mechanisms. So pain processing, I don't want to go too in depth, because it involves so many pathways, from the transduction and transmission of mechanical, chemical, thermal inputs from the peripheral receptors to the brain. But like all parts of the human body, there are anatomical changes that undergo age-related changes, from, looking at the myelinated fibers, the dorsal root ganglia, the spinal cord. All of these undergo changes with aging. But what does this actually translate to for the pain perception in elderly patients? There seems to be an increase in the pain threshold, meaning that often a stronger stimulus is needed before pain is perceived in elderly individuals. And that makes sense. It's consistent with declines in other areas of peripheral sensory systems, such as declines in like hearing, vision. So we're a little less sensitive. It might be due to reduced nerve density, altered nerve conduction. So they've shown that as we age, we get less sensitive to thermal, electrical, and pressure stimulation. But what's interesting is we might be more sensitive to mechanical pain. So it just shows how complex the process is. And it affects all types of pain too, like our sensitivity to chest pain during heart attacks. As we age, we actually become less sensitive to that type of pain. So even though elderly patients, for the most part, except for mechanical pain, seem to have a higher threshold, once pain is perceived, it tends to be less tolerated. So it could be due to higher levels of baseline inflammation, or from neuronal death from the descending inhibitory pathways that normally kind of tamper down pain. So again, once pain, it might take more stimulus for pain to be experienced, but once it is, it's more poorly tolerated. And I really like this graphic because it just shows some of the complexities of pain as we age. We might become less sensitive to heat-evoked pain, more sensitive to mechanically evoked pain. Some of the things that are protective are elderly patients tend to have better pain acceptance and less catastrophizing. But chronic pain is associated with worsening sleep, which is already a challenge in the elderly. And we're more sensitive once pain is actually experienced. So, does chronic pain itself accelerate the aging process? So, there is some evidence that it accelerates epigenetic aging. And epigenetics is the study of changes in gene expression without underlying the actual DNA sequence itself. So, they've looked at DNA methylation and shown that chronic pain might accelerate this process. There's also it's been linked to shorter leukocyte telomere length, which is a marker of aging at the cellular level. Musculoskeletal pain has been associated with significant decreases in healthy aging indices. And it's associated with increased risk of cognitive decline and dementia. But again, not all studies agree. Some neuroimaging studies show no evidence for global brain aging in chronic pain patients. Then going to the extreme, does chronic pain itself lead to premature death? And the studies definitely are not unanimous with this. There is some evidence. A study in Britain found that chronic widespread pain was associated with almost a 60% increased risk of all-cause mortality. And it's possible that plateau of chronic pain prevalence might be due to early mortality of chronic pain patients. But at the same time, it's really hard to separate the confounders. You know, Individuals with chronic pain tend to have increased prescription medication use, increased illicit substance use, dementia, falls, and the things that might be linking chronic pain and death, like inflammation, disease, might be what's causing the earlier mortality. So, how do we manage chronic pain in the elderly? Well, chronic pain is always challenging to manage for all individuals, but elderly patients present a bunch of unique challenges. The comorbidities and associated medications can interact with pain medications and tend to limit their use due to side effects, which I'm going to go into. Elderly Americans take an average of 4 prescription medications, and 41% take 5 or more medications a day. And the pharmacokinetics of many drugs are altered with age. And unfortunately, many pharmaceutical trials exclude older adults. So we don't always know the impact that these medications can have on elderly individuals. Looking at antidepressants and anticonvulsants, so the tricyclic antidepressants and serotonin norepinephrine inhibitors are frequently used in chronic pain, but the tricyclic antidepressants can cause hyponatremia from syndrome of inappropriate ADH secretion, and SNRIs have been linked to increased falls in the elderly. Gabapentinoids, which are used for neuropathic pain, which, like I said, is very common in elderly patients, tends to have side effects like dizziness, drowsiness, fatigue, weight changes. And again, none of these are absolute contraindications, but there are reasons that a lot of elderly individuals are hesitant, and a lot of medical professionals are hesitant to start them on these medications. Anticonvulsants used to treat neuropathic pain are often associated with cognitive impairment, sedation, and again, increased falls in the elderly. So NSAIDs, they inhibit prostaglandin synthesis, preventing COX-1 and COX-2 activation. They're very effective analgesics and anti-inflammatories, but long-term use tends to be limited in elderly patients from renal and gastrointestinal toxicity, because even as we age, kidney function declines even in healthy individuals, and it declines by about a third by age 80, even without any kidney disease. The selective COX-2 inhibitors like celecoxib, they tend to have fewer GI side effects, but their long-term use has been associated with increased thromboembolic events. So again, tend to be avoided in elderly individuals. Short term, though, in the operating room, which is where I primarily work, we do tend to use NSAIDs because they have been shown to be safe and effective for acute pain. But again, chronic pain, it tends to be avoided. Opioid dosing in the elderly should be reduced by about 25% for patients over 60 and about 50% for patients 80 and older. And this is for chronic and acute pain management. This is kind of a general approach to opioids. This is just due to the decreased renal and hepatic function and increased sensitivity that elderly patients have, and the higher risks of adverse effects like respiratory depression and sedation. Buprenorphine, which is a partial agonist, is actually being looked into a lot because its pharmacokinetics aren't as affected by age and renal dysfunction. And looking at chronic pain management from an interventional perspective, like from epidural steroid injections, radiofrequency ablations, knee injections, hip injections, these are excellent alternatives, but the evidence for long-term safety in the elderly is limited, and many of our elderly patients are on blood thinners, which might limit opportunities to do these procedures. Quickly going over non-pharmacologic management. So they've looked at different cognitive behavioral therapies. PNE is pain neuroscience education, which has been shown to improve speed, pain, disability, and fear of movement in older adults. Exercise consistently has been shown to improve chronic pain. No specific type of exercise has been shown to be superior. But one study actually showed that exercise in chronic pain might reduce that telomere shortening that was found with chronic pain and aging, which is just interesting. And nutrition is always a hot topic, looking at, particularly since chronic pain is associated with inflammation, certain foods have anti-inflammatory properties, like the polyphenol-rich foods, which I have in this graphic over here. Things like apples, berries, even like dark chocolate, olives. And again, it's being looked into and would make sense, but no clear correlation with improving chronic pain. I quickly wanted to touch on caring for the elderly in the operating room, because this is kind of my specialty. So in the next 30 years, the US population 65 years and older is expected to grow from 62 million to 84 million, while 85 years and older is going to triple from 6 to 20 million. Based on one study, 11% of the total population reported having surgery within the past year or some type of procedure, endoscopy. It doesn't have to be, an invasive surgery. But the subset over 65, almost 20% had some procedure, often requiring anesthesia. And a recent manuscript showed that the 1-year mortality after major surgery in elderly individuals was incredibly, or quite surprisingly high, at almost 13%. So the goal is no longer to just survive surgery. It's really the post-operative outcomes that we care about, and preserving independence and quality of life. But unfortunately, loss of independence is really common after surgery. 35% of older adults with a new disability after surgery have no recovery. And they've shown that 26% of patients 90 years and older exhibited functional decline that was chronic after a surgical procedure. And one of the big topics is focusing on delirium versus postoperative cognitive decline. So postoperative delirium is a temporary condition. It's fluctuating changes in attention, consciousness, and cognition. It tends to happen within hours or days after surgery. Comes and goes and disappears about a week later. Postoperative cognitive decline is less well understood, but it's more serious. It's new onset, long-term cognitive deficits after surgery and anesthesia. This is something that a lot of elderly patients are concerned about. It's associated with memory impairment, diminished performance on intellectual tasks, difficulty concentrating. It can last from months to years. They're looking at a lot of things that increase the risk, such as frailty. Frailty is a multidimensional loss of reserve, and there's a lot of different frailty scales, but having a high frailty score quadruples the risk of post-op delirium and up to 5 times the risk of complications like mortality, non-home discharge, and developing a new disability. So this past year, the American Society of Anesthesiologists came up with this perioperative care of older adults getting surgery, inpatient surgery. And I just want to go over some of the recommendations that they had. And a lot of it is focusing on the preoperative evaluation, focusing on frailty and cognitive impairment, to the point that if someone is considered to have high level of frailty, maybe they shouldn't be undergoing the procedure in the first place, just given such high risks of uh, long-term poor outcomes. Patients with preoperative cognitive impairment are not surprisingly at higher risk for delirium, and patients that have delirium are at higher risk of this long-term postoperative cognitive decline. So these high-risk patients, they do recommend getting a multidisciplinary care team, often involving a geriatrics team and providing family education. Interestingly, they're not showing a superiority of regional and neuraxial anesthesia over general anesthesia. And the studies, are a little mixed on whether the patient is getting 100%, just a spinal anesthetic or spinal anesthetic with sedation. So they do need to work on teasing those out. But right now, there's no clear difference in outcomes between the type of anesthesia, general versus regional. And then, a big topic in the adult world is looking at total intravenous anesthesia, usually just like a propofol infusion, or the inhaled gases like sevoflurane, because these gases have been associated with decreased cerebral spinal fluid clearing of things that people think could contribute to post-op cognitive decline. But still, we don't have any clear difference between running a propofol infusion versus using inhalational gases. There's a little bit of evidence that dexmedetomidine or Precedex might lower the risk of postoperative delirium. This is especially studied in the ICU, where we use it for long-term sedation for patients to help decrease the risk of delirium. And lastly, like I said, chronic pain is associated with high levels of inflammation, and so is postoperative delirium and cognitive decline. But unfortunately, a meta-analysis didn't show a reduction in the incidence of postoperative delirium or cognitive decline with prophylactic dexamethasone, which is a great long-acting anti-inflammatory that we were hopeful might help with some of these outcomes. So in summary, pain management in the elderly is very complex to manage for patients, providers, and caregivers. Chronic pain becomes more common as we age. It's perceived differently, can be difficult to assess, and leads to poor quality of life and could accelerate aging itself. There's a new focus on identifying frailty in the before undergoing procedures, trying to prevent the delirium and postoperative decline. And recognizing these challenges is the first step, but we need more research because our percentage of elderly patients is only going to drastically increase in the coming years. And with that, I'd like to hand it over to Dr. Looney. Let me stop sharing my screen.
So I'm going to try to see if we could share now for me. Thank you so much, Dr. Schafer. That was wonderful. And I also want to say thank you so much to the Ann and Charles Johnson One Health Institute at AMC, to Drs. Quesenberry and West, and of course the coordinators for tonight, Valeria and Courtney, and Dr. Kovo. Thank you again. It's a pleasure to be with you and to share this presentation tonight and share the stage with Dr. Schafer. What I'm going to try to do tonight is give you just a little bit of rundown of some research that has affected the way that I practice managing chronic patients in pain. but also try to give you a little bit of a segue of how, as Dr. Schafer did, dealing with patients in the acute care setting, the acute pain setting, a surgical setting of anesthesia has influenced the way that I treat them chronically. And I'll start out by kind of going through just some research that was just profound to me as I read it over the last couple of years. This one piece of research was done out of the UK, was destined to try to find if this type of assessment, animal welfare assessment, almost like a pain score for a global quality of life in dogs, was helpful, number one, but also if it was predictable in terms of assessing dogs with chronic pain versus non-painful dog, and the way that they approach their life in many, many different aspects, not just for the painful condition that they had, which was musculoskeletal pain, but also the way they interacted with their human counterparts in other dogs, their caretakers in other environments, how they approached eating, drinking, all kinds of aspects of their life. And the research really was phenomenal in pointing out that the chronic pain affected almost every aspect of these dogs' welfare. Compared to healthy dogs, dogs with chronic pain did worse in almost every category, specifically much more worse in the emotional health aspect, as well as the social interacting with other dogs. And so, in terms of how this affected my practice, I think really what we have to start to think about is chronic pain is significant for the family as well as the individual pet that's experiencing that. And this was just musculoskeletal pain, but they found that the interactions in terms of other animals and other family members was just phenomenal. So it has a very big impact on the life of the family, and it's very important that we address that. Can this chronic pain really cause disease or add to disease in our pets? As Dillon had pointed out, there's really not a direct correlation between pain and a lot of diseases. However, pain, chronic pain in particular, and some diseases like Alzheimer's disease in people have similarities in the fact that chronic pain and Alzheimer's seems to upregulate certain areas of the central nervous system that are involved in stress and panic and a constant state of alertness. Once these areas become activated, the cells, in particular the glial cells, which are kind of the immune cells of the central nervous system, start to become more abusive, more clubbed, more active. And in the long run, with their changes, oftentimes we see that those cells overwork and there's a loss of the inhibitory mechanisms in both chronic pain and in the Alzheimer's disease. And sure enough, there was a study that looked at whether there was any relationship in dogs with the same type of phenomenon. This was a survey of over 800 senior dogs and probably about the 25 to 30% last aspect of their life. They were surveyed for cognitive decline as well as the owners providing info on their dog's pain. And the highest level of cognitive impairment was seen in dogs that were most likely to have musculoskeletal or neurologic disease. And you might say, well, that figures because you could see those things rather dramatically. Well, you could see dermatologic disease as well, but that did not have a major predictive factor in joining with cognitive decline. So indeed, it appears that pain can add to, if not support, processes that are declining cognitively in dogs, just like in people. We know that pain is elusive in elderly humans, and it's difficult to diagnose in middle-aged pets by owners, guardians, by veterinary staff, much more difficult in the elderly patient. Dillon explained a lot of this in the facts that human patients have certainly a higher threshold for that acute pain, but as he said, when pain does occur, it's much less tolerated chronically, and it leads to depression much more readily. We know that in our veterinary patients, It's very similar. In fact, this was a study that aimed to investigate the agreement or the disagreement between owners of cats that were having questions about the impact of osteoarthritis on the cat's quality of life. And they surveyed a vet impression veterinarian who took care of that cat at the same time. And over 50% of the cat owners believe their cats to be perfectly healthy, when sadly enough, they had a very profound clinical diagnosis of osteoarthritis. So human patients aren't alone in kind of deciding that this is harder to show as they get older. In terms of dogs, this was a study that looked at dog owners given a questionnaire that engaged them about the dog's quality of life in 4 different areas. And they were asked about these areas to try to determine whether they could really diagnose pain in their pets appropriately. And what became apparent as the study went on is that recognizing pain as the patient aged became more and more troublesome. Large breed dogs and heavy obese dogs, the owners definitely had an easier time telling about their quality of life. But overall, pain was just considered a variant of normal aging. So we know that pain assessment can be very difficult in our veterinary patients. And typical of the first study that I showed you this evening, the more we look at the global welfare of those patients, the way they interact with their human counterparts, as well as the changes that happen in other body systems, their behavioral changes, their social and psychological interactions, the better we can diagnose chronic pain. A good example of this is, we do a lot of cruciate surgery in dogs, and we send animals home with special harnesses on them that help to lift up the back end as well as the front end. But we never think about the frustration that owners face when putting on those harnesses, and the dermatologic issues that accompany those harnesses, as well as the eating difficulties from just standing with that type of a harness on. And that dog really suffers, sometimes not because of the surgery, but because of what we have done to try to help that patient. And the family trying to get that on, and the dog recognizing that frustration can add to a lot of that painful syndrome that we often see with aging. The good news is that conversation can help. If we took some time, as this study showed, to kind of educate our owners about this welfare situation of the family and the pet, much more than just pain scoring, and maybe having much more to do with behavior and facial expression of those pets, then dog owners' perception actually rose to go ahead and appreciate pain in those pets more. So there's a good way out of the whole situation if we educate about that and have that conversation with our owners. How does chronic pain happen and occur? Dillon went through this a little bit, but I think, we used to think that acute pain happened suddenly, it was over. Chronic pain was that acute pain that lasted for more than 3 months. That 3-month time period, there was always that kind of line in the sand that decided acute versus chronic pain, and it was a temporal line. But what we now know is that pain is not really a reflex arc. It doesn't allow a person or a pet just to get away from something. The changes that happen along that pathway from transduction, transmission into the central nervous system, the way that that signal is dressed with emotions and autonomic output, can really make or break the situation for having that pain become more chronic. If we just look at the nociceptors that sense a painful stimuli from the outside, what we see is that there's a lot of intermingling of not only dendritic fibers, or the ends of these nerves, these A fibers, but there's an awful lot of white blood cell interaction. And more importantly, there's a lot of satellite cells, satellite glial cells, and Schwann cells, which are kind of considered the gatekeepers, the cleaner uppers of the central nervous system, at a kind of at a midway between immune and the neurosystem, that can let loose a lot of inflammatory mediators that set off intracellular cascades having a lot to do with calcium and calcium cycling through the cell that can create chronic pain. And these cytokines that are released from these white blood cells, the injured nerves, etc., have a certain profound kind of sway towards tumor necrosis factor, interleukin-1 beta, and interleukin-6. And so what we see in acute pain, just as kind of an insult, almost like an evolutionary attempt to get away from pain, is really not indicative of what's going on under the surface. It's that simmering fire that's created in acute pain that goes on to stimulate the central nervous system. So as that signal gets relayed up into the central nervous system, there's a very specific area of the spinal cord. This is just a cross section of the spinal cord, and the butterfly shape that you see in the middle is the gray matter. The extra part of the spinal cord is the white matter, but that area of the gray matter that's uppermost in the back of our patients, it's called the dorsal horn, has a number of different modes of operation. It's a group or a centering of interneurons that can either create a huge deal out of that inflammatory soup, that burning embers, that fire that was created with acute pain, or it can simmer it down over time. And the way that that works is honestly through us creating a better environment once we realize that acute pain. So, if we can keep that area of the spinal cord in its normal working modes of receiving pain and having kind of a proportional response, or helping with some pain relievers, whether they're endogenous or exogenous, that's great. Hopefully, acute pain never turns into chronic pain. But if we don't do that well, then there's consistent upregulation and irritation of those nociceptors, especially by the time that signal gets to the central nervous system in that area called the dorsal horn. Bad things happen. Unfortunately, the interneuron pool gets turned on, and that cellular process that keeps a lot of bad things at bay, the inhibitory neurons start to die off, and suddenly we have nerves that grow different areas and function in different ways that they shouldn't. And overall, what happens is that area can't return to its normal state. And so chronic pain really isn't about time. It's about, as Dr. Schafer mentioned, that inability to have that central nervous system turn back to its original normal function. It's a pathologic problem, it's maladaptive, and it persists a long time beyond healing, having nothing to do with time. In fact, some of these changes that we know in our lab animal species can happen within hours in lab animals versus days or months in people and in our larger animals. And it's about a functional and a structural rewiring of the nervous system intermingling with immune cells. And it all starts with inflammation. So, this area is really where the focus of a lot of my and Dr. Schafer's interaction has come about in the anesthesia room in trying to figure out how we can soothe this inflammation better. And I'm not the only one that thinks that way. There's a great internist who has done a lot of writing. The term immunosenescence was coined by somebody in 1969 who felt that a lot of the aging process was due to autoimmunity. And inflammation is just an imbalance of the pro and the anti-inflammatory processes in the body that add to the aging process. And certainly the companion animal model, dog has been studied as a model for inflammation in people with these same cytokines being overly represented in the literature. And so if our own inability to treat that inflammation isn't bad enough, our inability as anesthesiologists, as nurse anesthetists to create this is also present. Poorly treated surgical pain can have these same problems. And in fact, in humans, as Dr. Schafer, I'm sure knows, there's just a lot of post-surgical pain from certain types of surgeries. Our patients can't really tell us about that, but we know by their focus on certain body parts or their inability to use them appropriately, or by the frustration of their owners with dealing with some of the side effects. Our patients have this too. And again, the risk factors in human medicine behind this focus again and again on inflammation. So knowing all this, knowing that our pets have like a global process because of pain, knowing that it can be linked to other diseases, it can be very difficult to recognize as our pets age, but it has its roots in inflammation. I think you guys get the point here, and I'm probably aging myself with this, but we really know that inflammation is very, very common, and we don't have to think about the actual insult. We have to think about that surgical simmering, that fire that keeps growing under the skin, and treat inflammation a little bit more effectively. So how should we do this in our patients? How does this influence the way that I practice chronically for my patients in pain, knowing what we know now? Well, as Dr. Schafer has indicated, there's a lot of considerations for humans going into surgery that we can try to simmer that inflammation prior to going in. Many of them have downfalls of ataxia and ability to fall that physicians, I'm sure, worry about. We worry about that in our patients as well, but we are starting to use some of these on a more regular basis. The traditional nonsteroidal anti-inflammatories can be used in our patients both chronically and acutely, and many of the pain management guidelines support the use of these drugs, even with this literature that's out there showing that these drugs can be used in patients that have renal compromise, liver compromise, and myocardial compromise. So it's no longer a question of whether we should use nonsteroidals in our chronic pain patients. It's kind of a question of when and what dose we use them in. And we can't forget to think about acetaminophen for our canine patients. We now have an injectable form of this that we can use perisurgically. It's an excellent drug to reduce inflammation in the central nervous system, but the thought process on how it does that has changed. We used to think that this works on a inhibition of a COX type of variant, but now we know it in dogs and cats, it's converted, dogs and exotics, it can be converted to a breakdown product called AM404, which interacts with endocannabinoid and TRPV receptors. Again, these processes just kind of helping to simmer down a lot of that inflammation within the central nervous system. And in people, there's been a focus on treating inflammation perisurgically by looking at a few key areas, reducing weight going into surgery, trying to treat those comorbidities ahead of time. Dr. Schafer mentioned the use of buprenorphine, which is great because we have that in our profession, and we should use probably more of that, but also by looking at the use of local regionals and ketamine in our patients. And I'll finish by kind of talking about them. We've used these anesthetically for decades now, and we just need to see these drugs in a very new light. Ketamine has a lot of evidence in terms of reducing the need for isoflurane and sevoflurane in many, many species, and used at unbelievably low doses. So we're very lucky to have this in our profession. I think a couple of years ago when the WHO almost put this on a back order and a controlled substance list that would have limited it to veterinary medicine, how we would have suffered because it's such a useful drug. But not many of you probably know it's a great anti-inflammatory in addition to an anesthetic. And that anti-inflammatory pathway probably works through these very specific receptors on the cell surface, one of which is called the toll receptor, toll-like receptor, which influences a lot of the NMDA transmission of calcium into the cell and can really reduce inflammation in that pathway. It also has an influence on the chironeuronine pathway, reducing a lot of substances which reduce the ability of nerves to regenerate and transmit appropriately. So it tends to be an excellent anti-inflammatory. Lidocaine, we've known about its anti-inflammatory effect for a long time, especially in terms of our equine patients and our rabbits, in terms of their motility and their gut ability to heal. We have started using this in our chronic pain patients, given on a monthly or a 6-week basis, regularly to reduce the chronic pain in many of our oncology patients, as well as chronic medical patients. And local blocks in particular, we use a lot of in the acute pain setting for either fracture or elective orthopedic surgery. But not many of you probably knew local blocks have an excellent anti-inflammatory effect in people and in our veterinary patients. And this anti-inflammatory effect, again, focuses on those changes in those cytokines, the tumor necrosis factor and interleukin-6. So there's some excellent work out there to show the anti-inflammatory effect of these products, things that we've used in an acute pain setting for a long time. There was just an interesting study done around the time of COVID, and you might say, you know, I have lidocaine in my practice, but I don't know enough about using it in local blocks. There was a study in COVID patients that when lidocaine was given just intradermally or subcutaneously or even around lymph nodes, it reduced the inflammation in COVID patients enough to allow an earlier release and prevent them from going on a ventilator. So just the simple use of this mucosally can really activate so many things in our patients. So I guess my take home that I'd like you to leave with tonight is really trying to focus more on inflammation, and in doing so, seeing that the origin of a lot of pain is inflammatory, and we have a lot of useful tools within our profession that we can use. And hopefully this will help treat not only your acute pain patients, but your chronic pain patients, the elderly patients, really establishing a huge part of that population. And I thank you guys for joining us this evening.